Hey guys, this is the last part of substance use disorders. Hopefully it works this time when I upload it. So benzodiazepines, so we've kind of covered this here and there. And the effects: CNS, depression, sedation, hypnosis, amnesia, death. Remember that there's various half-lives, and so you expect to see the duration change. You also expect to see the onset of withdrawal change, and so that's kind of where some of this comes from. Just remember that, the shorter the half-life, the more rapidly the withdrawal symptoms start. Half-lives greater than 96 hours, they kind of have a self-tapering action. And then for benzodiazepines, they produce an amnesia-like effect. And the one that, is no longer available, it used to be indicated for the treatment of short-term insomnia, is flunitrazepam, which is Rohypnol, which, if any of you guys are old enough, will remember is the date rape drug. And so it's no longer available on the market, and it's obviously illegal. So benzos, we again kind of touched on this, more severe with shorter acting drugs, anxiety, tremors, twitches, nausea, vomiting, convulsions. So you can have seizures with benzodiazepine withdrawal, but it's usually day 8 or 9. Compare that with what we had with alcohol, where you typically see withdrawal seizures in the first 12 hours and as soon as 2 hours. And so, benzo withdrawal can be life-threatening, and we kind of talked about this with depression. Benzos and alcohol are the two withdrawal syndromes that can kill you, but by and large, alcohol is the one that will kill you faster. And so, benzodiazepine withdrawal it's rarely fatal without co-ingestants. If somebody overdoses, protect their airway, their breathing, and their circulation. You intubate them if you need to, you decontaminate them, and then flumazenol. So flumazenol is the reversal agent for benzodiazepines. It's highly controversial because if somebody's on benzodiazepines long term and you give them flumazenol after they've ingested too much benzodiazepine, you can actually cause seizures. And so flumazenol isn't really used in somebody that's on benzos long term. Maybe it's used in somebody, think about the grandmother who has a prescription for Xanax, and, she has a grandchild come over and the grandchild accidentally gets into it. They swallow a bunch of tablets, take them to the ER. Then you would argue for the use of flumazenol. You're not going to use it in somebody who's been on opiates for a long time because you don't want to cause withdrawal seizures. So then we have our stimulants, so caffeine, which it actually isn't in the DSM-5 anymore, but it can. There is addictive properties to caffeine, so you just kind of want to be careful there. Nicotine, definitely. So our treatments of that are replacement therapy with patches, gum, and lozenges. Then we have bupropion, we have Wellbutrin, and we also have something called Chantix or varenicline. So there's plenty of options there. And then stimulants, so ADHD drugs, ecstasy, cocaine, releases catecholamines, activates sympathetic nervous system. You get intense euphoria, so think, and I've never had this, but it's always been kind of described to me this way, but think runner's high, so that rush of adrenaline gets you that really good high feeling. That's what these cause. That's what they mean by euphoria. And so they decrease fatigue, they increase alertness, but you do see tolerance developing rapidly. Again, remember receptor theory. So clinical effects, just talked about this. Excess can cause paranoid schizophrenia. Overdose can cause a rapidness, appetite, exhaustion, depression. So kind of the opposite, because essentially you've overdosed the receptors, you've exhausted the receptors, and so you get the opposite effect. So amphetamines are rarely fatal, but you manage those with benzodiazepines to calm them down, and then supportive care until it wears off. Amphetamines typically wear off pretty quickly. So cocaine, So cocaine binds to the alpha and beta receptors, specifically in the brain. It gives you that rush, that feel-good feeling. There's dopaminergic qualities to it. Treatment, this is rapidly fatal, so treatment, airway, breathing, circulation, ABC, supportive care, treat with symptoms, and in the outpatient setting, you don't give beta blockers. And the reason you don't give beta blockers is because, remember, it can bind to both alpha and beta receptors, and so if you give a beta blocker, where's the cocaine going to go? Well, it's going to go to the alpha blockers, and so the alpha receptors. There's alpha receptors in the arterioles, and so you'll cause those arterioles to clamp down. You'll shut off all circulation. Remember, our third thing, our C and ABC is circulation, and so you're not supporting circulation. They have no blood flow, they have no oxygenation, and then they die. So what you have to do is you have to give something called phentolamine, which is an alpha blocker, and then you give a beta blocker, and then that prevents that sympathetic nervous system activation. The other thing you can do is use Coreg. So Coreg has alpha blocking activity and beta blocking activity. And then ecstasy, kind of the same thing as the other ones, management, supportive care, ABC. We have hallucinogens. I'll let you read through that. Just know that they mimic all of the neurotransmitters, so that's how you kind of get that feel good. And then, again, I'll let you read through this. You're not going to see too many of these, but hallucinogens, you're going to treat it with benzos. You're going to monitor them. You're going to use supportive care, and then for the ones that have that are antimuscarinic in nature, or for the ones that cause acetylcholine binding or mimic acetylcholine binding, you can give physostigmine, which is an anticholinergic inhibitor, and it reverses the anticholinergic effects. And then you have marijuana, so cannabis, THC. You see here it's kind of onset of action. There is one that we do use in cachexia, cancer-related nausea and vomiting, called Marinol or dronabinol, and it's a purified form of marijuana. And so they're talking about oral administration down here. This is really more for, your special brownies and cookies and all that. Marinol does have a similar peak in duration, though. And then the effects, I'll let you guys read through that as well. Tolerance, you see more of a psychologic tolerance with heavy long-term users. There's no physiologic tolerance. There isn't really a physiologic addiction per se, but there's definitely a psychological component to marijuana. Inhalants, you won't really see them as much anymore. These are typically, you'll see these in younger kids that want to quote-unquote experiment with drugs, and so that's when you have to worry about it. They can cause cardiac arrhythmias, and so you manage those. It's really just side effect, really just supportive care. So here are the toxicities. They can cause pretty profound toxicities, all of them put together, and so you want to keep them away from this as much as possible. Last, we have steroids, and I mean anabolic steroids, not your prednisone, prednisolone. So anabolic steroids, you see cyclic abuse, 4 to 18 weeks on, 1 month to 1 year off. And then you get withdrawal syndrome. So remember, as soon as you withdraw testosterone, testosterone kind of has a neuroprotective effect as far as depression and fatigue. And so you withdraw that, and you get, basically you're not making testosterone anymore because you've been giving yourself something that has told your body, hey, you don't need to make testosterone anymore, and so it shuts it off. And so they get depressed, they get fatigue. Side effects, cognitive impairment, and then you get increased aggression because remember, they're using a lot of steroids, and testosterone is the aggression steroid or hormone, quote unquote. Changes in libido and sexual function, and then it's hepatotoxic, so you can see jaundice. You'll also see, again, you see here the elevated hemoglobin hematocrit because it's involved in erythropoiesis, increased LDL, testosterone is associated with increased cholesterol, LFTs, hepatotoxic, and lower FH levels because it's a negative feedback loop. Clinical findings, you'll see these. You'll see hirsutism in females, so they'll start growing hair. Gynecomastia in hirsutism in females. Gynecomastia in males, they'll start growing breasts. Needle punctures because that's the only way that they can give it to themselves. And really the treatment is peer counseling, group support, and then consulting with fitness experts. So that's all I have for you. The cases will be up shortly.